Um, Thank you all. I know it's a snowy day today, and I wasn't sure how many people would come down today. It's a pleasure to have Dr. Shandong Wu here. I just learned that he didn't have to give a job talk when he joined PIP. So, so fun and surprising.
They like it. They like me.
Yeah. But his background is in computer vision. Then he was at Florida, then at Penn before coming to PIP.
Okay, thank you. Thank you. It's a great pleasure today to talk about some of the work that we have been doing the past few years on breast imaging. So I put a radiological word in the title because I know this is like pathology, interest group, but I thought let's try to put this word to highlight that. So the images we're processing or we're dealing with in our study is basically the radiological images. So um, first, what we do. So I try to give you a general sense of what we're doing here. So our group is trying to interface in three, different areas. We do computational imaging analysis and also clinical breast imaging, which is very close to the clinical workflow, and also the machine learning and big data analysis. So we're trying to, work on these different areas. And those are some of the more specific areas we're working on that. For example, of course, we need to do quantity analysis. We need to develop a lot of algorithms, computer-based tools, models, and also we do a lot of imaging-based clinical studies. We collect real-world clinically routine acquired images and do a lot of analysis, for example, doing imaging-based biomarkers and responses biomarkers. And also we're using the machine learning-based method to do a lot of interpretation of the big imaging data and also the radiomics and radiogenomics. So today I'm going to focus on one topic, imaging biomarkers for risk assessment. So we will talk about how we develop a new quantitative biomarkers from the images, clinical available images. And the risk is we're talking about the risk of developing breast cancer. Okay, so this is most likely in a screening context. So there's other risks, for example, the risk of recurrence for breast cancer patients, which is the work that we're also doing, but we're not talking about this today. And also we can talk about the responsive biomarkers to intervention. For example, some of the high risk women, they take medicine, they take interventions, and we want to know whether they're responding to this. So the whole talk will be, I'll give you a mixed flavor about computational pipeline, the methodology, no details though, and quantitative data analysis, and then the clinical cohort studies. We use a lot of real-world clinical images. And then at last, I will give you a very short introduction about how we're using machine learning to do some data-driven biomarker discovery. So in the United States, the general risk for women developing breast cancer is one woman, 8 women, there's one will be developing breast cancer in lifetime risk. So these are considered like general population risk level for women. There's a lot of risk factors, ages, your genetic factors, family histories, and some others lifestyle related. But interestingly, we know that there's like 60 to 70% patient, they don't have any, we know they're breast cancer patients, but they don't have any known risk factors. So there's a lot of potential to discover new risk factors. So that's here the imaging come to play, and we want to look at that how we can look at the imaging features or imaging patterns, breast tissues, or some of the biological properties of breast tissues that it can have to do with breast cancer risk. The images in the clinical setting, so we do in the early detection and screening, we do digital mammography. This is the standard imaging for screening, and also those days increasingly digital breast tomosynthesis as a kind of quality 3D imaging also being used, and it's going to replace digital mammography in some days, years maybe, not days. Breast MRIs also for high-risk women. We'll talk about this. This is our focus today talk, and also ultrasound images. So let's start with breast density. So the breast density is a kind of it's a very important concept in here when we talk about risk. So for 3D breast images, you do a digital mammography images, and these images give you a overview. Of course, this is a 2D projection of the 3D breast, so to give you overview about the distribution of the dense tissues, which is here the brighter regions here. So back to actually 40 years ago, Wolf's work has been showing that the breast parenchyma patterns, distributions, or how the image look like, it had to do with the risk, from the lowest risk to a highest risk for different patterns. And those days, this has been further developed based on the, for example, the ACR virus system, the breast density categories. There's 4 categories: fatty breast, scattered dense breast, heterogeneously dense breast, or extremely dense breast. So those are indicating a different level of risk. So, so a very important question will becomes how we, quantify those dense tissues. Also important to mention is in this, in United States, more than like 27 states have passed a law to require the health provider to send a woman a letter after the digital mammography-based screening, tell them their breast density information. So because density has to do with your risk levels. So in this letter, it's basically, tell the patient what are the limitations of the mammography. It has limitations because it's a 2D imaging of the breast, 3D breast. And also, some of the research results about the implications of higher risk or lower risk based on the dense tissues, and we just showed it here. So, for example, if you give a scatter or heterogeneously, dense different categories, it indicates a different level of risk. So then, so the problem becomes how we quantify those images or assess the images. Clinically, we using virus-based category. You're using those different words. You look at that visually and you give a qualitative assessment. Of course, there's a lot of variabilities, and people have developed some semi-automatic based techniques. For example, in the very simple, using thresholding technique. You define the breast area and then the dense tissue area. You control the threshold and get a region of that dense tissue. You compute a percentage of dense tissue. And also, there are some actually commercially available software, Vopra and Quantra. They can compute a volume-based breast dense tissues. Now, because the digital mammography is 2D images, but they're using some of the basics or the relation of the physics imaging of the physics, they can estimate a volume-based breast densities. Now, the problem with this method is it requires raw images. So in the clinical setting, the images, digital mammography, when they acquire the images, it's called raw images. And then they further process these images in order to better show this to the radiologist to better look at these images. So there's different ways we call it raw images or processed images. So unfortunately, the raw images in most medical centers, they don't save this because it uses a lot of spaces. So if you only have the processed images, you cannot use this software to compute the volume-based numbers. So in my previous lab, we have been working on a method to develop a automatic computer-based algorithm that can work on both raw images and processed images so that we can quantify the area-based breast density. And this measure has been used, it's publicly available, and has been used in many places. Going beyond the amount of the dense tissue, when we compute the number, the percentage of the dense tissues, people also, there's a lot of work on compute, for example, texture features. They look at some of the macro structure level of dense tissues and see whether this had to do with risk. And a lot of findings has shown that it actually shows, some more information that the amount of dense tissue is breast cancer. So give a short, yes.
So that kind of data, do people have some ground truth, or how do they do it? Are radiologists all agree with that label?
So you mean the label or the race?
For the quantitative stuff that comes out, how do you say this is a good measure?
Yeah. That's a good question. So for the density assessment, so the issue is there's no ground truth. So if you ask a radiologist, no matter who you ask them, they might give you this is virus 2 or 3 or 4, and there's a lot of variation, and we know that, but there's no ground truth. And even, for example, for some of the tissues, some of the part of the tissues, if you ask a radiologist, here, how you quantify, which part are very dense tissues, there's still a variation on that. So there's no very, like a gold standard, like pathology, you say there's cancer, not cancer, or malignancy or not malignancy. So there's no ground truth on that. So basically, in some of the previous work, people have been using this as a ground truth. They ask a radiologist to do this, based on your visual assessment, based on your experience. And when you say these are dense tissues, you think these are dense tissues. Yes. Yes.
So there's commercial software that does this visual analysis. People that developed that software actually have patients that were imaged with mammography and then with MR. So they have 3D tissue volumes. They do the measurement, calculation on that, and compare it to the MR. So there's sort of like indirect validation of that software. But basically, whatever most often, whatever the radiologist is going to the same.
Yeah. So people try to correlate it with like MRI. For example, MRI give you a 3D, kind of real 3D assessment. We will talk about here in the later. But in general speaking, there's no, even you have very high correlation, people can still argue, this is real or, but the problem here is like, how accurate you need this to be. For risk assessment, these are we're talking about your risk is relatively high or lower. Even this kind of binary tree, I think it's already very helpful. You don't have to be very accurate like. So that's the context. For summary with screening the mammography is, so this is the only test so far proven have decreased the mortality. So the limitation is, of course, these are 2D images. So we know breast has 3D structures. There's a lot of tissue in position and low sensitivities because some of the dense tissue can mask the cancer. Even there's cancer, you can't see it. You just can't see it. But still, this is a routine clinical breast cancer screening examination for general populations. I want to talk about a little bit more now, look at the specific subpopulation of women that are considered high risk or elevated risk levels. Those women are usually, for example, they have known genetic mutations like BRCA1 and 2, or have strong family histories, or based on some kind of risk models, they have 20 to 25 greater than this number life risk. Usually they're considered high risk. And when you're considered high risk, in the clinical setting, you actually can do a additional imaging, for example, breast MRIs. And only you qualify for high risk definition, insurance will cover for the MRI. So the MRI is not available for general population for every woman. Now, when you have MRIs, of course, you will have more information maybe there, right? Compared with digital mammography. For high risk women, even they are considered high risk, their risk level is still vary a lot, for the individuals. And also, when women are put, they were told, oh, I'm high risk, then they worry about that. So they can choose to do some intervention to reduce your risk. They do mastectomy, or they do oophorectomy, or they do, take some drugs to reduce their risk. So, and this come to, but all this intervention, reduce some risk. For example, the mastectomy really reduced risk, but it all has very substantial side effects. These are, as you can see, those are surgeries, or those are very big decisions for women to make, in order to reduce the risk. So also, when you do these interventions, actually for a specific woman, you don't know whether they will respond. For example, you can take, you do sublingual oophorectomy. We will talk about in the study later. You do this, but you don't really know whether it really reduces your risk to a, minimal level or some levels. Because some women after surgery still can develop breast cancer. Okay, so that's where we want to develop a risk markers, for example, for find whether women will respond to the surgeries, to the interventions. Now, so what we'll look at going beyond the breast density in digital mammography, we look at some of the features of breast tissue properties in MRIs. First one is we talk about the 3D dense tissue. We just mentioned that. In MRI, you have a 3D volume, right? You're supposed to get a better, more accurate assessment of dense tissue here. So whether this has to do with risk. The second thing is we call the background parenchyma enhancement. This is the enhancement of the normal, the so-called normal tissue. For example, women presented for screening, there's no cancer detected, or, so it's still a healthy, cancer-free woman, but some of the tissues, dense tissue, they still enhanced when you have the breast MRI contrast agent injected. So what this has to do with breast cancer risk. And also we look at the kinetic features in the, when you have multiple post-contrast sequencing MRIs, the kinetics of the normal breast tissue, how this has to do with risk. So the three words, FGT, BPE, and the kinetics, I will use very intensely later. Remember what they mean, okay? So clinically, those are FGT, BPE also, again, using bias-based assessment, using this qualitative words describe that. And you can see here, mild or moderate. It's very hard actually clinically to distinguish those, because even radiologists have a lot of different, a lot of variations. So it is close, subjective, a lot of greater variation, difficult to standardize. For the kinetics, we know the kinetics has, it reflects dynamic of contrast agent uptake. It has been used in the clinic to do the diagnosis. For example, different shape of the curves can indicate it's benign or it's malignancy. This has diagnostic value for lesions. But how about for the normal tissues? There's no lesions found, just normal parenchyma tissues. So we also look at the features, the kinetic feature for that part. So there are several components that I'll talk about here. The first one, we'll talk about how we do the computational processing of the images, because you need to quantify those features automatically. And also we look at that clinical study, how we using, we design a study to see whether BPE and kinetics had to do with risk. And we also have another study look at that, how those features change over time. The third one we'll talk about, if these features are indicating the risk, or so-called risk biomarkers, the goal is we want to incorporate them to the current risk model to improve the risk prediction accuracies. Okay, that's the ultimate goal of using the find of these new markers. And the last is we want to look at that how those features maybe also can measure the therapy or intervention response, as I mentioned earlier. So we will talk about when women doing saphengophrectomy study surgeries, how this had to do with risk, and women doing steady exercise, how this had to do with risk, and something about endocrine therapy. These are something ongoing work, but I will talk about that. Okay, the first part is more computational. So I will quickly go through some of the work, no details. So given the breast images, we first quantify, separate the whole breast agent, because those are not breast areas. And then we quantify this FGT, fibrogranule tissue, dense tissues. So finally you get because the 3D imaging, you get a 3D volume of the breast and the tissues here. So then we can translate all those masks to the post-contrast or subtraction images. And within here, because they are contrast agent or uptake, after the uptake, you see the enhancement here. So we find out those voxels that are enhanced. And then those like purple voxels here are the enhanced normal breast tissues. So then these are basically the BPE. So we can compute the absolute volume of those voxels, or the percentage of this volume relative to the dense tissue or the breast. And these are kinetic features using the multiple contrast sequences. Okay, so first part, this is considered pre-processing, but this is actually very challenging work. For example, when you get, so we want to find the breast regions, but if you look at some of the images, clinically available images, it's very challenging. If you look at the chest wall line here, visually you can see that, but for the computer, it's very difficult to find this. So we developed some kind of work method to find the edges here. You have to link them, and also of course we're also developing using model-based method. But those methods, appear to work pretty well for some of the challenging cases, as you can see here. Given this, you can find the breast regions. It's pretty good. And this is a result that we compare the automatic based method compare with manual segmentation by radiologist, and those are 3D volume of the breast, and there's a difference between that. There's a pretty high agreement. Now, when you have the breast, then further we will within this area find out these areas, the density. So we have several methods evolves. So just talk about the last one. Before we do the imaging, the density segmentation, we will also do some kind of correction on the bias field, because there's a lot of concerning noise in signal in MRIs. And then we build an atlas with this distribution of this dense tissues, and then we can do that. So if you look at these examples, so we need to first do some kind of normalization with the scans across different patients, so that you can have the computer quantifying the regions of interest. And we also can project the breast in a different, breasts have similar but different shape. Then you can actually projection in a similar one atlas or space and find out likelihood of distributions, and using this as a prior to help you do the segmentation. So those are the images, input images, and then after several processing, you get a images here. So look at it. Sometimes you think these are all just simple to find this area, but it's actually not. If you look at it here, for example, the intensity. If you just look at intensity, it's very close to here, but those are biased fields, so it's not part of the breast at the dense tissue. This is an example that we compare with different method and manual segmentation. Again, there's no ground truth for here. Okay, as you can see here, we can only get manual segmentation from, these are two different radiologists, and you can see they give there's a variation on that. So we're using their consensus reading. We find agreement between them, and then to compare with the method. So those are the data showing the correlation between different radar-based and computer-based assessment. Okay, the third part will be, once you have the breast, you have a dense tissue, then you want to identify the BPE here, the voxels here. This is a relatively easy work because you just look at the voxels, look at how much enhancement there, right? But still, because there's no established, for example, thresholding about how do we define the voxel is enhanced, is it 20% enhancement or 40 or 50? There's no standard enhancement definition. And clinically, radiologists using their visual assessment, you don't know what threshold they are using. So we actually, okay, so these are, shows how we do the BPE, different steps. This is, based computer-based, and this is a manual segmentation based on radiologist assessment. And this figure shows we did an experiment, if we don't know what a threshold is the best or is optimal, then we just look at the whole range. We can quantify that, and we find out there is a actual range. This range, once you put the enhancement in this range, actually it has a higher correlation with radiologist assessment. So this way you can get a sense about what threshold in radiology are using. But of course, for the analysis, you can try different threshold. Okay, so we have those all techniques available that we can process images. Given the MRIs, we can quantify that in a few minutes for one scan. We can automatically do this for hundreds of women's scans. And then we can do a study, look at it, how the FGT, BPE and kinetics has to do with risk. So I present this work and this work. So these are studies. So in this study, we have like case control study, retrospectively collect images. We have about 102 women. Half are unilateral breast cancer cases, half are matched controls. So we have in total 102 MRI scans. And all those women have a suspicious abnormality and detected during the standard examinations, and they have virus 4 or 5 diagnoses, and they do the biopsy. Some are cancer and some are benign. So there are two groups of women. So we compute, those are the imaging protocols. I will just skip that. So for those images, we just compute using the method to compute the breast, find the breast regions, dense tissues, and then the BPE and the kinetic features here. Those are different kinetic features here. And also, like you can see, these are different views. These are actual views of breast images. So these has to do with where the different medical centers protocols. And we computed several kinetic features: the peak enhancement, time to peak, and wash in slope, wash out slope. Those are standard features that are computed for tumors or lesions. We're computing this for normal tissues. We also compute a signal enhancement ratio here using the first and the third different subtraction sequences. So this has been shown in other previous study, has to do with measuring the response of chemotherapy. And that's why we're looking at this feature as well here. So we do statistical analysis, and we compare the contralateral breast for both cancer cases, and cancer and control cases. Because once you have cancer here, you can't compute the BP stuff, because cancer will affect that. So these are results. Those are two groups of women. You can see they have very similar ages because they're matched, monopodal status and family histories. So basically, we want to try to find the cases that control the two groups. They have very similar risk profile, for example, in terms of age or other factors. And then we can see how their imaging features are different between two groups. And those are the cancer types. Most are invasive cancers in terms of size information. So, okay, let's look at the results. For breast density, actually, if you look at the virus breast density for mammography, those patients also have mammography. You can see here there's basically no difference, significant difference between the two groups. So breast density in this specific cohort is not significant to predict the cancer control status. However, when we look at the BPE, okay, the MRI FGT, the 3D density also is not predict the status here. So the density tissue here in MRI actually for this work is not associated with risk. And then when we look at the BPE, we do univariate analysis and multiple variable analysis. Basically, we control some other factors, and they look at the odds ratios and the p-values. They all show a significant association. Means the BPE has to do with risk for this group. This concordant with two reader studies that have been published before. And if you look at the AUC, actually here, just look at the BP single variables, okay, not other risk factors. If you just compare with very basic information like ages, then you get an AUC, in this low range. But when we added the BPE, it have a significant increase with that. Still, those number AUC compared with some other numbers may not very high, but this is the kind of in the range of the risk models, because some of the clinical use models, their AUC is actually 0.6 or 0.7. So these are in the range. You're not expecting some AUC like 0.9 or something here. These are not in that range. When we look at the kinetic features here, those are different kinetic features. Odds ratio also shows associations. And very importantly, when we added the BPE here, we control the BPE. We show BPE has to do with that. But if you adding this here, you see that the kinetic features is even more robust than the BPE. So that shows maybe those other kinetic features is more, another more robust risk factor than BPE. So this is the first. So our group published this work the first time, to look at the kinetic features. And again, in terms of AUC, so if you look at it here, BP is about this numbers, kinetic feature is about this number. You put them together, these numbers. Again, here is only, the imaging feature. We are not considering other features. So okay. So I'm gonna talk about when we talk about the BPE we're using, because there's multiple different post-contrast sequencing MRIs. So the first one, second one, third one at different time point. So which one are you using to do the quantifying BPE? The recommendation is using the sub-1, but there's other research or argument that people want to use some different other sequencing to see whether this had to do with risk. So we do a study to compare the early or delayed DCE sequences. As you can see here, we do the same thing with the BPE. We look at in the different subtraction or post-contrast sequences, we find a very similar association with that. That means if you look at the AUC, it's very similar. So that means if you quantify BP in different time point sequences, it may not matter that much. So this as a background why we are doing this, because breast MRIs, people can say, MRI is very expensive and it takes longer time to get. For screening, it may not be the best one. It's like, few thousand, dollars, expenses. So, and there's a lot of research these days pushing the trend to look at, some kind of simplified protocols for breast MRI screening. So they say we don't need the whole protocols, full sequence of MRIs. We can just look at, for example, we just need one or two sequences. We don't need T1, T2, we don't need the FLIR, we don't need all this stuff. We're just using, a single or very limited number of sequences to see whether this can still do a good job for screening. And so in that context, to look at that, different sequences, early or delayed post-contrast sequences had to do, has value, in order to in this context. So these are called abbreviated or fast breast MRIs. This study, I will quickly go through its longitudinal study we're working on right now. So this is look at, this purpose of study is look at that, since we find this had to do with race. Now, we also do some calibration work. For example, I'll give you an example. For example, we say blood pressure is a marker for a lot of disease, right? But then you know the normal range of blood pressure. You know, when in this range you're okay. When you go to the extreme, not in that range, you say something wrong, right? So the BPE is the similar thing. If you say this is a risk factors, we try to find what is the normal range of that, right? If you're very high or very low, maybe it give you it calls you to think about very high risk or low risk. So the similar concept. So we look at some of the high risk screening women, breast cancer free women, okay, no cancer developed. Look at their longitudinal breast MRIs over time. How those changes before any development of cancers. So this is will be considered a calibration of the BP levels and how this changes. So yes, I will just skip that. I will try to show some of the results here. So we have in this study we have about 100 patients, have about 500 scans. So you average for each woman it has 5 sequential MRIs or negative MRIs. And some are BRCA mutations, and those are breast cancer free status in about 2 years after the latest MRIs. So make sure they are cancer free. So those are their some of the other properties, menopausal status, whether they are the surgicals, whether they take hormones, but this all can affect the breast the BPEs, family histories. So this is all the plot, of the distribution of those BPE percentile, and you can see this is the mean value and the standard deviation. So this is like give you a sense about for this woman's average number for that. And we look at the correlation between the left and right breast because there may be difference or highly correlated, and we do see higher correlation, but we also see left breast actually have slightly higher BP than right. We don't know what the reason of that, but this is what we'll find out. It may have to do with where your heart is left, right? It has to do with different, supply of, blood or everything. It may have to do this. So this table is very important. Shows we do a linear mixed effect model. Look at it, from the baseline 0 years and 5 years later, how those measure changes. And we find the BP changes over time, decrease, and no matter it's post-menopausal women or pre-menopausal women, we also find the decreases. So, and we find the BP is lower for post-menopausal first, and then they all decrease over time. Actually, for different, menopausal status, the rates are also different. So this is an example showing, for example, this woman is a post-menopausal woman, has all 4 scans every year. They have MRIs. And we quantify those features, BPE, you can see here, you do see a decrease of that. Okay, so the third aim, I have only one slide because this work we're still not yet finished, honestly. We're still doing a study, but based on some of the work that I just showed you, for example, when we have a basic information here, and we added the imaging features, it indeed gives you improve that. But this is not conclusive because these are not in a real risk model. For this risk model, you need to have a lot of other risk factor to be considered. So this is not a comprehensive analysis, just very preliminary results showing that a potential of that. So the last one we look at that, okay, the BPFGT, how this had to do with measuring your response for interventions. For example, we look at the first one, we call it risk reducing salpingo-oophorectomy. You basically take out your ovaries to reduce your ovarian cancer and breast cancer. And also, the women doing exercise. So let's look at that one. So I using this to, kind of education. Angelina Jolie in 2013 and 15, she did a double mastectomy first, reduced breast cancer risk, and salpingo-oophorectomy 2 years later to reduce ovarian cancer risk. Because she is the BRCA1 mutation carrier. She has strong family history, very high risk, and she did doing this. And she, wrote articles in newspaper and to share here, why she didn't make a decision on that. Actually, there's research on that, like how Angelina Jolie effect, can, for the general population, when they have similar situations, do you want to do the surgery of this? Do you want to do this? But, it has actually have a effect on that. So the risk reducing sublingual oophorectomy is basically surgery reduce, improves organs and fallopian tubes. So this can reduce your risk for breast cancer and ovarian cancer, but there's no established standard to identify which one will benefit on that. We don't know. We know generally it's reduced risk, but we don't know for a specific one whether you will respond. So we did a study that has about 50 women. These are all BRCA1, 2 high-risk women. So they have the surgery, they have MRIs before and after the surgeries. So, and out of those 50 women, six developed breast cancers even after the surgeries. So we will look at that, how those imaging feature changes for the different group of women. So this example shows, for example, when you look at these are pre-surgery, after surgery, these are FGT and a BPE. So if you look at the 44 women who didn't develop breast cancer after surgery, at least by the time of the study, the follow-up, study, you see here there's significant decrease of the BPE. But for those 6 women who develop breast cancers, in average, their BP remained in the similar levels. So this tells us, if you look at those, because they have to do with risk. If you find that, after surgery, your BP actually didn't really going to decrease, then you might still have at higher risk, of developing breast cancer. So the AUC here also tells us when you're using the BP and FT together, it really can predict the developing of the 6 women, the development of the breast cancers. So this study, of course, this is a small study. There are, only 50 women, 6 cancer cases, but it's very hard to get those kind of data, for this kind of cohort. But still, this study very encouraging that, if we look at your BP and FGT after surgery, you have MRIs, it can help you determine maybe whether you will respond to that, right? Just look at the BP, how this level changes. Actually, after the publication of this work, we did receive one patient sent us an email saying, I'm going to do this surgery. Is your method, will be able to quantify, whether my BP will change or not? Because she wanted to know whether she will benefit from this. So it has, great clinical value. Another study I'll look at that, exercise. Exercise is something, it's not aggressive. Every people can do this. So we look at whether there's a dose-response effect for women taking steady exercise on the high-risk women. So this was study in collaboration with Penn. So we had that study recruited like 139 patients, randomized in 3 groups with 6 months follow-up. So all these women are asked to do, high-dose group, high-dose exercise. Every week you do 300 minutes exercise. Low dose is 150, or control groups you don't do anything, just as usual. So we have MRIs acquired at the baseline and follow-up for 6 to 8 women. Not all those patients, because the grantee cannot actually have money to do this for all cohort. But even for the 6 to 8 women, the subset, we still have very interesting finding here. So I will just skip those, patient population stuff. So we look at it. Actually, in addition to imaging this study, they also test your blood, the blood level, estrogen levels, all this stuff. So, they present in the paper, but I was showing the imaging finding here. So we look at that, the BPE, the baseline BPE in the baseline MRIs, and after the exercise, what is the BPE level after exercise? After 6 months is basically. So let's look in here. So this figure shows the ratio of this post divided by the baseline, the pre. So if you look at the control group, so this value is about, it's greater than 1. That means your BP value after exercise is greater than baseline. And for this low dose group, it's also greater, but it's lower than this value here. But for the high dose group, you can see here, the after exercise, the BP level actually lower than baseline. And if we show BP has to do with risk, then this may tells you that if you do high dose exercise, your BP may be decreased, and may be indicating a decreased risk. Of course, I see these are 68 women, not a very large study, but this finding actually is consistent with the the blood testing findings at certain levels. So when we actually, the first time when we would do the analysis separately, when we meet together, we were pretty excited about that because, we find the same thing from different analysis, imaging and other tests. So this we don't have the results yet, but I just want to talk about that. So, for example, you do surgery, you do exercise, but you can also take medicine, for example, tamoxifen to reduce your risk, for example, recurrence risk. These are more, for example, you have a breast cancer, right? Then you taking the tamoxifen to reduce your risk. The problem is this drug is you have to use it for a long time, 5 to 10 years, reduce your risk, have substantial side effects. So then clinically, a lot of women, they cannot take that for a long time because, they don't really know whether I can benefit from that, and a lot of side effects. So if we know that, we can tell them, in the early time whether you will respond from taking this medicine, it can encourage them, or encourage them to take this medicine for a longer time or shorter time. So breast density, mammography breast density has been in a study showing that only patients who experienced a decrease in MBD may benefit from tamoxifen. That means only when you take some medicines, you see your density decreases, you might be responding for that. Similar concept with like the surgery, so surgeries, you do the surgery and then you see the decrease of the BPE. So maybe you're responding to that. So we're currently doing a study on that. We will report the results later. So I take a few minutes to talk about, we say, using machine learning to do some kind of data-driven biomarker discovery. So those people are, very popular to using deep learning, using convolutional neural network. So you build a model to process breast images. We have done a lot of preliminary results here. So I'll present 2 here. The first one is more likely a validation or, feasibility study. For example, when I talk about this breast density qualitative assessment, this Batty, standard or heterogeneous density or this. Let's talk about these 2 groups because for these 2 groups, those are the population distribution. The most of women are in this category, these categories. If you're in here or here, it's easy, people can easily find you here or here. But for these 2 groups, it's very hard, difficult to distinguish them, even between the experienced radiologists. However, if you put a woman in this category or these categories, it can have a different consequences because if you are in these 2 categories, you're considered dense breast, you're considered higher risk. If you are here, you're considered lower risk. Okay, so you don't really want to people if they're lower risk, you put in higher risk, you put in low risk, because when we deliver this information to patient, this patient will consume this information. Oh, I'm high risk, but maybe you actually are scared just because these variations of radiologists you might be accidentally or wrongly put in these groups. So we're trying to using the deep learning based method to build a reader or quantitative reader or classifier to classify these 2 categories. Maybe this can be used to help radiologists make decisions. So I'm going to show you one result here. So we collect about 20,000 images actually. So we find it, it's a scattered versus heterogeneous dense tissue, dense breast. So we're using like 6,000 for training and using about 700-800 for testing. So this is AUC. If you look at this AUC here, it's very high AUC here. It's a very good classifier that can help you distinguish the 2s. And we also tested when you're using transfer learning, for example, when you started with, if you don't have that many images for training, for example, right? You're just using some transfer learning. The model was trained based on some natural images database, like ImageNet, and then you're using a smaller number of cases to train that. You still get a pretty good performance with that. So this gives you a sense that maybe for this specific task, the transfer learning can help on that. Oh, which one?
Green to train says 6,000, or training says 6,000.
Yeah, there's a little bit of variation on that. But they're still closer. What?
The transfer learning is hurting that thing.
I think if you look at a chain, I don't think you can say hurting. It may be for specific.
Well, if you do a training size of transfer learning for the dollar.
Yes, yes. You could argue, you could say that, as I say that we do transfer learning, you try to say that if you do, for example, you give like 1,000 here, if you see like 0.5 or 0.6, we just wanted to see whether, how this can, can be, for a different task, this can hurt. You might just get 5.5, 0.6. But these numbers are showing that, of course, for this specific, I can just use this, I don't need transfer learning like that. But I'm saying if you don't have that number, those 6,000 images, right? You just want to say, I only have 1,000. Only 1,000. How this can be used? Can I still do this?
The test where you train on only 1,000 amount of transfer learning, you got a first A, B, C,
we're using transfer.
Did you train with just 1,000?
No, we had a result we didn't present here. I was asking my postdoc, but we didn't get time to prepare all this.
Yeah, we trained with the 1,000 and
we're still analyze the data. Yeah, those are very fresh data. So, yeah, but just give you a flavor. These are because people can argue. Like for standard or heterogeneous things, because as I said, there's no ground truth here. People can say, this may be wrong. So we have.
Those data are coming from one radiologist?
Yeah, no, they're a mix of radiologists, not only one radiologist. We actually did some pre-processing about we did. There's a lot of data here. I didn't present. We actually did also find out some of the cases that we find it's less likely. It may be wrong. It may be wrong. For example, if we do the quantification of the breast density, and we find the scatter is like much higher than heterogeneous things, then it's making less sense in clinical setting. So we actually include that cases, But even you do the exclusion or not do the exclusion, the finding is very similar. Okay, some change with that, but still in a similar level. So, yes. What?
Why are the data points all
Here?
Yeah, why they spread out?
I think that's how to do with how we plot the ROC, right?
Yeah, this is the value. Yeah, it's threshold.
So there should be 1,500 values.
Absolutely.
Because you have testing at 836.7.
No, but I think only some threshold for the ROC between.
For the ROC, you don't pick all the threshold, you just do threshold.
Well, no, you go to the next value, sort of. But so this is saying that you're only returning maybe 10 unique values across those 1,500. That's what that looks like, which is very strange for us.
Okay, we can look at it here. Maybe you can find different threshold in here. And I said these are, yesterday's results, so I'll try to give some. Yeah. Also, another one.
That might explain it. Like at first, the data points inadequate. You can tell it. Sure.
But that could mean that there's a data set that's all getting a 1.0, for example. But that could,
Right.
You'd have to look at the logic.
But it's highly unlikely that the very first data point on the right-hand graph is that close.
No, if there's this class of images where they're all just saturated, saying this is 1.0, and some percent of them are not ones, they're zeros, they're false, whatever.
I think we're also look at you have different way to compute the AUCs using some other functions. I guess we're getting similar results. Yeah.
This is two classes, right?
Two classes.
Oh, two classes.
Yeah, only two classes.
One is the totality. The totality.
If you were to use a non-deep learning method for performance.
No, we didn't do that. Well, I think we need to do that. And I told him if you some of the paper people will ask, if using some other feature. Yeah. So another one is this is even So maybe I should not present too many preliminary results, but So another, we do the case control study. These are like for the biomarker stuff. We will look at that, in addition to the density or picture analysis, can we find some other features? So we look at that case control study. We have a new data set, about 100 cancer, 100 controls. We look at their prior negative images, not the images with cancer diagnosis. And then we also do a classification of those all negative images before they develop cancer or remain cancer-free. And we find the preliminary result AUC like this. We don't get time to plot that, but we will look into this. And just for comparison, if you look at the breast density, it's only 0.52. So this is the big difference with that. And of course, unpublished data when you look into this, but I think there is something, we have to compare this with texture, of course. There is something maybe beyond those features that can be captured by texture or density. Actually, we'll review one paper this last week. It showed the features using the deep learning-based feature extraction. It did capture additional features that can complementary to the standard texture features. So, okay.